Thank you for the introduction, Professor Dong and Professor Wilson, Professor Jian and Professor Dong, Professor Wang, and all our colleagues. And it's my great honor to join this joint session of GW-ICC and ACC. And I will give a brief introduction for the diagnosis and treatment of the advanced heart failure. And this is my contents of my speech. The first is about the definition of advanced heart failure. So according to the AHS heart failure guideline, the advanced heart failure is the stage D of heart failure. And there is some characters for the definition of advanced heart failure, which include the patients have a severe and persistent symptoms of heart failure and have a severe cardiac dysfunction defined by at least one of the following, such as have a very low EF or very dysfunction of diastolic heart failure function, and also the episodes of pulmonary or systemic congestion requiring high dose of diuretics, or the episodes that requiring the inotropics or vasodilator treatment. And the fourth of the character of advanced heart failure also often need severe impairment, often combined with severe impairment of exercise capacity, such as the low 6-minute walk distance, or the peak VO2 is very low. And there is some similarities or differences of different guideline or consensus, but most of them focus on several main factors that I just listed. And there is a different heart failure stages or the multi-classification. We use the HA class 4 or the stage D, or when we use the Intermax profiles, and this is a different multiple classification of advanced heart failure. And for the patients with advanced heart failure, most of them will endurance the episodes of worsening heart failure. And there is some more new definition of the worsening heart failure, which be defined by escalating signs or symptoms of heart failure in patients with chronic heart failure, despite previously stable therapy. And many patients experience episodes of clinical worsening over time despite a stable therapy. And there is some characters that reflect the new theory that the worsening event is preceded by gradual progressive subclinical worsening and a subclinical high-risk state that follows an apparent clinical recovery or discharge. So the epidemiology or prognosis of advanced heart failure, there is some epidemic study, and if the patients have more worse advanced heart failure, the mortality is higher in stage D heart failure patients. And the 1 year mortality rate of patients with advanced heart failure is between 25% to 27%. And according to the new data that from the National Cardiovascular Disease Center, for Chinese hospitalized heart failure patients, the re-hospital rate of in 30 days is about 30%. That data need to be published in recently. So also the survival and hospitalization rate of advanced heart failure is very worse compared with the stable heart failure patients. So how to make the evaluation of advanced heart failure? There is some key factors which showed the characters of patients of advanced heart failure, which include the repeated episodes of cardiac decompensing and the frequent hospitalization and the prolonged hospital stay and the severely impaired quality of life. And this is the character which be marked, the markers of advanced heart failure that the I need help, which will indicate the different characters, including the treatment and rehospitalization, and also the very severe dysfunction of such as very low EF and have the very severe arrhythmias. And also, this is the clinical indicators of advanced heart failure, which published in last year, and also shows the similar key characters of advanced heart failure. So how to treat the advanced heart failure? There is according to the guideline recommendation, include the drug therapy and the device therapy. So for the therapy of advanced heart failure, I think there is also some key factor, key management for the advanced heart failure, which include the 4 parts. And the first is the volume management. This is the first step for treatment of advanced heart failure. The volume assessment is very important. In clinical practice, we often to combine the signs and the symptoms together, and also include the examination of chest X-ray or vena cava imaging or using the lung ultrasound. And in the future, we can set up a very multi-factor for the risk stratification or price evaluation of the volume assessment of advanced heart failure. It is important to guidance the treatment of volume management. And this is the Chinese expert consensus, which published 3 years ago. We also make the combination of clinical symptoms, clinical signs, and also the preliminary monitoring indicators. And if we need more precise evaluation, the intravenous invasive indication, invasive examination is also needed, such as the Spangans and other evaluation method. And maybe in the future, according to the evidence, we can add such as pulmonary artery pressure monitoring or other non-invasive pulmonary volume examination or the telemonitoring for the volume status for heart failure patients. So for the treatment of volume management for heart failure patients, this is the position paper that to to give guidance for the use of diuretic therapy. And at the usual time, we will double or triple the dosage of diuretic dosage compared with the usual dosage, and to make a very carefully evaluation for the effect of the diuretic, and to make a judgment so we can get quickly and precisely volume resummation for the advanced heart failure patients. And for the advanced heart failure patients often have the diuretic resistance, and there is some factors or reasons for the diuretic resistance, such as there is a threshold dose for the diuretic, and also have the breaking phenomenon, and also have the hyponatremia or hyperoxemia, and also have severe infection. So we can give some management for the diuretic resistance, such as a combination of different mechanisms of diuretic therapy, and also we can to make the supplement to increase the blood flow to the kidney, to give a resummation for the iron disturbance. And there is some new trial just be talked in the ESC guideline. First is Edward trial, and the result shows the supplement, the addition of acetazolamide to the standard diuretic regimen, which cannot further to improve the outcome. And so there is no difference between the two groups. And another is a chlorotic trial that also shows the supplement of the treatment with hydrochlorothiazide can cause more incidence of the increase of creatinine, and also there is no further improvement for the diuretic effect or improves the outcome. And if there is the diuretic resistance, and the oral diuretic therapy is cannot to resolve the volume problem, and the blood purification therapy is needed. And for the heart failure patients, that we can use the ultrafiltration, and it be recommended at the in the guideline, and the recommendation is to be and be considered in refractory volume overload, responsive to diuretic treatment. And the second key management is to how to management for the hemodynamic disturbance. And we can use the vasodilator and inotropic drugs and vasoactive drugs. And the congestion is the main reason for advanced heart failure patients. And we can use about 4 vasodilator, which recommended in the guideline. So in this field, because such as the TRUE trial and also other trial that maybe in the future we need a new vasodilator treatment for the advanced heart failure. And the second part is for the inotropic drug therapy, and it is also very important for the advanced heart failure patients, combined with low output and there is some different mechanism and hemodynamic effect of vasoactive drugs. And in clinical practice, we usually make the combination of them together because despite their frequent use, few clinical outcome data are available to guide the initial choice of vasoactive therapy in patients with advanced heart failure. And there is only little RCT study. The SURF2 trial, which shows the use of dopamine was associated with a great number of adverse events. And the optimal CC trial also shows the use of epinephrine compared with non-epinephrine was associated with similar effect on the arterial pressure and cardiac index and higher incidence of refractory shock. And also for the DOREMI trial, which showed in patients with cardiogenic shock, no significant difference between meridone and dobutamine was found with respect to the primary composite outcome. And so the recommendation from the ACC AHA guideline that for patients with heart failure, the long-term use of either continuous or intermittent intravenous inotropic agent can maybe cause do not improve the outcome and maybe only used as the bridge to advanced therapy. And for the second key part is the cardiac shock management. I think Professor Wilson will give a very excellent presentation. So I just give a brief introduction. So for the cardiac shock, we need to give the effect treatment to prevent the cardiac shock to go into the worsening stage. And for the treatment, because most of them caused by the coronary artery disease, so we can give the strategy according to the cardiac shock combined or not combined with the acute myocardial infarction. And it is very important for the MCS treatment. And there is different characters of different MCS. And in Eurotime, we need to combine to use them together. For the IBP, although the SHOCK2 study showed there is that IBP cannot to improve the outcome, but in China, we think it is cheaper and more convenient, especially for low-level hospital. So maybe we can to use them at suitable patients. And the VA ECMO is very popular now for patients with cardiac shock treatment. And this is a recommendation of the MCS treatment in the ESC guideline. And it can be used as a bridge to the heart transplantation LVAD. And LVAD developed very quickly in China, especially for the domestic LVAD. And this is the main brand of the LVAD, which already launched in China. And for example, the cohort 6 LVAD, it is the pump weight is only 90 gram, and it can be used in China in the future after the clinical trial be finished. And totally nearly 93 LVAD implanted have been completed, and the 3-year survival rate of domestic LVAD patients in Fuwai Hospital is better than that of HeartMate 3. And this is, but for the LVAD treatment, we think we need to, according to the guideline, and to make a very strict indication evaluation. And for this patient, it is the very oldest, more than nearly 80 years, and also have a lot of comorbidities. And after nearly 3 years treatment, and be to successfully be taken the LVAD, and now have nearly go back to the normal life. And the heart transplantation in China also developed quickly, but there is some limitation for the donation number. So now in Fuwai Hospital, nearly 1 year, nearly 100 heart transplantation be taken every year. And for the comorbidity treatment is also important. And for the advanced heart failure patients, also often combined with cardiovascular comorbidity and or non-cardiovascular comorbidity. So we need to treat them together and make the whole factors strategy, and to give the patients very multiple and enough treatment. And the fifth part is about right ventricular heart failure management. It is very important because it is a limitation contraindication for the LVAD or the transplantation evaluation. And we also to make a precise evaluation for the right heart failure. And there is also short of RCT study, and we just give the management of right heart failure, focus on the management of volume and the preload and the myocardial contractility, and the reduce the RV afterload with the pharmacotherapy and also the MCS. And I think in the advanced heart failure also need very good administration, and some patients need to be referral to the advanced center of heart failure, and this is the guideline of 2 steps for the advanced heart failure, and we need to find out the characters which need to be transferred to the tertiary heart failure center. There is the characters including clinical, laboratory, and imaging, and other factors. And we need to set up the referral network for the advanced heart failure. And in China, we also set up the National Heart Failure Medical Union, and this be helpful to make a very administration for the heart failure patients. Thank you so much.